Welcome back to PNB Wellness Academy. Today, we're making antidepressants simple and focusing on the high-yield concepts you need to recognize for PMHNP boards. There are a lot of antidepressants, and trying to memorize every detail about every medication can quickly become overwhelming. Instead, I want you to make connections. For each major medication or medication class, think about the mechanism of action, major clinical uses, important side effects, contraindications, monitoring requirements, and the patient characteristics that may make one medication a better or worse choice. We're going to cover SSRIs, SNRIs, atypical antidepressants, tricyclic antidepressants, and MAO inhibitors. We'll also discuss antidepressant discontinuation syndrome, serotonin syndrome, treatment-resistant depression, augmentation strategies, psychotic depression, and ECT. As we go through these medications, pay particularly attention to the clinical clues. On boards, you may not simply be asked which medication belongs to which class. Instead, you may be given a patient with depression and neuropathic pain, a patient who develops a widened QRS after an overdose, a patient who develops clonus after taking serotonergic medications. Your job is to be able to recognize what those clues are telling you. Before we prescribe an antidepressant, we need to know what we're treating. A major depressive episode requires at least 5 symptoms occurring during the same 2-week period and represent a change from previous functioning. At least one of those symptoms must be a depressed mood or loss of interest or pleasure, also called anhedonia. Siggy caps is a useful way to remember many of those symptoms. You want to remember sleep disturbance, decreased interest or pleasure, guilt or feelings of worthlessness, decreased energy, difficulty concentrating or making decisions, appetite or weight changes, psychomotor agitation or retardation, and suicidal thoughts or recurrent thoughts of death. Remember that depressed mood itself is also one of the 9 symptoms. The board connection is 5 symptoms at least 2 weeks, and depressed mood or anhedonia must be present. The symptoms must also cause clinically significant distress or impairment, and you must consider whether substances, medications, or another medical condition could better explain the presentation. One of the most important things to do before prescribing an antidepressant is to assess for bipolar disorder. A patient with bipolar disorder may first present to you because they are depressed. Ask specifically about previous periods of mania or hypomania, decreased need for sleep, unusual elevated or irritable mood, increased energy, grandiosity, pressured speech, racing thoughts, increased goal-directed activity, impulsivity, and risky behavior. Don't assume that because the patient presents with depression, they have unipolar depression. This is clinically important because treatment of bipolar depression differs from the treatment of major depressive disorder. An antidepressant monotherapy may contribute to mood switching. So you want to remember, depression comes through the door, but bipolar disorder still needs to be ruled out. Now we'll discuss SSRIs. SSRIs are selective serotonin reuptake inhibitors, are commonly used as first-line pharmacologic treatments for major depressive disorder and are also used for multiple anxiety and trauma-related disorders. As a class, you want to remember that they may cause GI upset, nausea, diarrhea, headache, sleep disturbance, sexual dysfunction, sweating, and possible activation or increased anxiety when treatment is first initiated. More serious concepts include serotonin syndrome and antidepressant discontinuation syndrome. Another important counseling point is time to response. Patients may notice some improvement during the first couple of weeks, but fuller therapeutic benefit often takes approximately 4 to 6 weeks, sometimes longer depending on the patient and disorder being treated. This matters on boards. If a patient has taken an antidepressant for only a brief period, is tolerating it, remains safe, but has not yet had an adequate therapeutic trial, immediately declaring treatment failure and switching medications may be premature. Now you want to separate the SSRIs because each one has an association I want you to recognize. So we'll start off with Prozac or fluoxetine. Fluoxetine should immediately make you think long half-life. Its active metabolite, norfloxetine, remains in the body for a prolonged period. Because the medication essentially tapers itself as concentrations decline slowly, abrupt discontinuation tends to produce fewer discontinuation symptoms than shorter-acting medications such as paroxetine. Fluoxetine can also be relatively activating, so consider the patient's symptom profile when selecting it. A patient already struggling with significant activation or insomnia may require additional consideration. The long half-life becomes particularly important when switching medications. So if you're switching from fluoxetine to an MAOI, you need a much longer washout period than you would with most other serotonergic antidepressants. Your board association is simple. Fluoxetine equals long. Next, we'll discuss paroxetine or Paxil. Paroxetine should make you think almost the opposite, discontinuation. Its shorter half-life contributes to a greater likelihood of antidepressant discontinuation symptoms when it is abruptly stopped. Paroxetine can also be relatively sedating. It has more anticholinergic activity than many other SSRIs and may contribute to weight gain and sexual dysfunction. Pregnancy considerations are also important, and other SSRIs are generally preferred when clinically appropriate. If your question tells you that a patient abruptly stopped an antidepressant and subsequently developed dizziness, nausea, anxiety, flu-like symptoms, insomnia, or unusual sensory disturbances, paroxetine should be high on your differential. So you want to remember, paroxetine has a shorter half-life. Next would be sertraline or Zoloft. Sertraline should make you think GI effects, particularly diarrhea. That's one of its classic medication-specific associations. Sertraline is also commonly considered when antidepressant treatment is needed during pregnancy or breastfeeding, based on individualized risk-benefit assessment. So your quick association is sertraline equals gut drama. Now we'll discuss citalopram or Celexa. Citalopram can be associated with QT prolongation. This effect is dose-dependent, so cardiac risk becomes particularly important at higher doses and in patients with other risk factors. Pay attention to patients with underlying cardiac disease, electrolyte abnormalities such as hypokalemia or hypomagnesemia, congenital long QT syndrome, or concurrent medications that also prolong the QT interval. If a board question gives you an SSRI and specifically draws your attention to an ECG or QT interval, think citalopram. Escitalopram is commonly used for depression and anxiety because of its general favorable tolerability profile. QT effects are still possible, but citalopram carries the stronger classic board association with dose-dependent QT prolongation. Fluvoxamine or Livox should make you think OCD and drug interactions. It has an important role in OCD and is also a clinically significant inhibitor of several CYP450 enzymes. That means you need to look carefully at the patient's medication list because fluvoxamine can increase concentrations of interacting medications. So memorize this SSRI board map. Fluoxetine, longer half-life. Paroxetine, shorter half-life, discontinuation syndrome. Sertraline, GI. Citalopram, QT. Fluvoxamine, OCD, and interactions. So let's talk about serotonin norepinephrine reuptake inhibitors, or SNRIs. They inhibit the reuptake of both serotonin and norepinephrine. Because norepinephrine is involved, cardiovascular effects such as changes in blood pressure and heart rate become particularly important. First, we'll discuss venlafaxine or Effexor. Venlafaxine should make you think about two things: blood pressure and discontinuation. Venlafaxine can produce dose-related elevations in blood pressure. Venlafaxine also has a relatively short half-life and is well known for producing antidepressant discontinuation symptoms when stopped abruptly. Patients may experience dizziness, nausea, anxiety, irritability, flu-like symptoms, insomnia, imbalance, or sensory disturbances, sometimes described as an electric shock sensation or brain zaps. A patient should generally be tapered rather than abruptly stopping venlafaxine. So what's important to remember with venlafaxine is elevated blood pressure and discontinuation symptoms. Next, we'll talk about Cymbalta or duloxetine. Duloxetine should make you think mood plus pain. In addition to depression and anxiety disorders, duloxetine is used for several pain conditions, including diabetic peripheral neuropathy pain, fibromyalgia, and chronic musculoskeletal pain. If a patient has major depression plus neuropathic pain, duloxetine may allow you to target both problems with one medication. Hepatic considerations are also important. Be cautious in patients with substantial chronic liver disease or substantial alcohol use. Your board association is duloxetine dulls the pain. Then there's desvenlafaxine and levomilnacipran. Desvenlafaxine is a major active metabolite of venlafaxine and shares many SNRI class effects, including potential blood pressure elevation, sexual dysfunction, serotonin syndrome, and discontinuation symptoms. Levomilnacipran is another SNRI with relatively prominent norepinephrine reuptake inhibition. So our memory associations will be venlafaxine equals elevated blood pressure and discontinuation, and duloxetine equals pain. Now we'll discuss our atypical antidepressants. We'll talk about bupropion, mirtazapine, and trazodone. These are extremely testable because their adverse effect profiles are distinctive. Okay, so bupropion primarily inhibits the reuptake of norepinephrine and dopamine, making it an NDRI. Unlike SSRIs or SNRIs, it has minimum direct serotonergic activity. That gives bupropion an important advantage. It tends to produce less sexual dysfunction than serotonergic antidepressants. A patient who develops significant sexual adverse effects on an SSRI may be a candidate for bupropion, depending on the rest of their clinical picture. Bupropion is also used for smoking cessation, but here's the safety concept you absolutely need to remember. Bupropion lowers the seizure threshold. Bupropion is contraindicated in patients with a seizure disorder and in patients with a current or prior diagnosis of bulimia nervosa or anorexia nervosa because the conditions increase seizure risk. So if the question gives you a depression plus a seizure disorder, bupropion should not be your answer. If it gives you depression plus bulimia or anorexia, again, avoid bupropion. Your board association is bupropion, dopamine, and norepinephrine, smoking cessation, it has fewer sexual side effects, and avoid if there's a risk for seizures. Now we'll discuss mirtazapine or Remeron. Mirtazapine should make you think eat and sleep. You want to remember that. It has strong antihistaminergic properties and commonly produces sedation, increased appetite, and weight gain. Sometimes what we call a side effect can actually help us choose the medication. Imagine a patient with depression who tells you, I'm not sleeping and I don't have an appetite and I've lost weight. Mirtazapine's profile may actually match the patient's symptoms. Now reverse the situation. Your patient is already struggling with obesity and stopped a previous medication because of weight gain. Mirtazapine may not be your best choice. This illustrates a larger psychopharmacology principle. Choose medication based on the patient, not simply the diagnosis. For memory, you want to remember mirtazapine equals mattress plus munchies. Then there's trazodone. Although trazodone is classified as an antidepressant, at lower doses its sedating properties are much more prominent, which is why it's commonly used off-label for insomnia. Its antidepressant effect generally requires substantially higher doses than the lower doses commonly used for sleep. It can also cause orthostatic hypotension and next-day sedation. The classic board adverse effect is priapism. A prolonged erection lasting approximately 4 hours or longer is a medical emergency and requires immediate evaluation. If the question gives you a sedating antidepressant used for sleep and then mentions a prolonged erection, you want to remember trazodone. Let's move on to tricyclic antidepressants, or TCAs, which include amitriptyline, nortriptyline, imipramine, desipramine, clomipramine, and doxepine. TCAs inhibit the reuptake of serotonin and norepinephrine, but they aren't selective. They also antagonize muscarinic histamine H1 and alpha-1 adrenergic receptors. That broad receptor activity explains much of their side effect burden. The muscarinic blockade produces the classic anticholinergic effects: dry mouth, blurred vision, constipation, urinary retention, tachycardia, and confusion. Histamine H1 blockade produces sedation and weight gain. Alpha-1 adrenergic blockade produces orthostatic hypertension. This is especially important when you're treating older adults. A highly anticholinergic and sedating medication that also causes orthostatic hypotension can contribute to confusion, urinary retention, constipation, and falls. Always consider the patient's age, medical conditions, and fall risk. Now let's talk about the major TCA emergency. TCA and overdose. The TCAs block fast sodium channels in cardiac tissue. In overdose, that sodium channel blockade can impair cardiac conduction and cause life-threatening cardiotoxicity. Patients may develop hypotension, arrhythmias, seizures, altered mental status, and coma. The classic EKG clue is widening QRS. If you see a patient with suspected antidepressant overdose and a widening QRS, think TCA toxicity. The classic treatment for significant TCA cardiotoxicity is IV sodium bicarbonate. This is one association I want you to memorize exactly. TCA overdose equals a wide QRS, and you will need sodium bicarbonate. Also remember that clomipramide has an important association with OCD. Okay, now we'll discuss monoamine oxidase inhibitors, MAOIs. Monoamine oxidase normally breaks down monoamine neurotransmitters. When the enzyme is inhibited, concentrations of neurotransmitters such as serotonin, norepinephrine, and dopamine increase. There are two major forms of monoamine oxidase, MAOA and MAOB. For depression, MAOIs are generally not first-line medications because of their substantial dietary and medication interactions, but they remain important for boards. One classic association is atypical depression. Think mood reactivity, hypersomnia, increased appetite or weight gain, leaden paralysis, and rejection sensitivity. Tyramine is the classic MAOI dietary interaction. Certain aged, fermented, cured, or improperly stored foods can contain high amounts of tyramine. In a patient taking an MAOI, excessive tyramine exposure can produce a dangerous catecholamine surge and result in hypertension crisis. A board question may describe a patient taking an MAOI who eats a high tyramine food, then develops a severe headache, palpitations, and markedly elevated blood pressure. You want to think MAOI plus tyramine equals hypertensive crisis. MAOIs can also interact dangerously with serotonergic medications and cause serotonin syndrome. Appropriate washout periods are essential when switching between these medications. A general high-yield rule is approximately 14 days between an MAOI and many contraindicated serotonergic antidepressants. But there's one major exception you should know: fluoxetine. Because fluoxetine and norfluoxetine remain in the body for so long, you generally need to wait at least 5 weeks after stopping fluoxetine before starting an MAOI. Let's discuss serotonin syndrome. Serotonin syndrome is characterized by a combination of mental status changes, autonomic hyperactivity, and neuromuscular hyperactivity. Mental status findings include agitation and confusion. Autonomic findings can include diaphoresis, hypothermia, tachycardia, hypertension, and diarrhea. Neuromuscular findings can include tremor, hyperreflexia, and clonus. For board purposes, I want you to remember clonus plus hyperreflexia. You want to remember serotonin syndrome. Management begins by discontinuing the serotonergic agents and providing supportive care with additional treatment based on severity. Before we discuss treatment resistance, let's separate antidepressant discontinuation syndrome from relapse. Abruptly stopping certain antidepressants can cause flu-like symptoms, insomnia, nausea, imbalance, or dizziness, sensory disturbances, and hyperarousal or anxiety. A useful mnemonic is FINISH: flu-like symptoms, insomnia, nausea, imbalance, sensory disturbance, and hyperarousal. The two medications I especially want you to associate with discontinuation are paroxetine and venlafaxine. Fluoxetine is much less likely to produce an abrupt discontinuation symptoms because of its longer half-life. Now, suppose your patient says, my antidepressant isn't working. Don't immediately switch medications. First, ask whether the diagnosis is correct. Did you screen for bipolar disorder? Is the patient actually taking the medication? Has the patient reached a therapeutic dose? Has the trial been long enough? Are adverse effects affecting adherence? Are substances, medical conditions, or medication interactions contributing to it not working? Is this a no response, a partial response, or intolerance? Remember, the fuller antidepressant efficacy commonly requires several weeks. Your general strategy becomes optimize, switch, augment. Medication selection should also be individualized according to the patient's history, symptoms, medical conditions, previous response, side effect concerns, medication interactions, and preferences. If a patient previously stopped the medication because of weight gain, don't ignore that and select another medication likely to create the same problem without a compelling reason. If the patient is struggling with insomnia and weight loss, mirtazapine's profile may be beneficial. If sexual dysfunction is driving non-adherence and there are no contraindications, bupropion may deserve consideration. If neuropathic pain is prominent, duloxetine may make sense. That's the clinical reasoning boards are looking for. Let's talk about augmentation. For patients who have had an inadequate response despite an appropriate antidepressant trial, augmentation may be considered. Certain second-generation antipsychotics can augment antidepressant treatment. Examples include aripiprazole, brexpiprazole, and quetiapine extended release. When these medications are used, remember appropriate monitoring for medication-specific risk, such as weight gain, glucose and lipid abnormalities, akathisia, and other extrapyramidal symptoms. Let's talk about psychotic depression. If major depression occurs with delusion or hallucinations, you want to think major depressive disorder with psychotic features. Treatment commonly involves an antidepressant plus an antipsychotic or ECT. Do not treat the psychosis as though it were uncomplicated non-psychotic depression. ECT or electroconvulsive therapy is one of the most effective treatments available for severe depression and is particularly important when a rapid response is required. You want to remember ECT when you see severe treatment-resistant depression, psychotic depression, catatonia, severe suicidality requiring rapid intervention, or severe functional deterioration such as inadequate eating or drinking. If a board question emphasizes severe, urgent, rapid response needed, ECT should move high on your differential. A major adverse effect to recognize is transient cognitive impairment and memory disturbance, particularly around the treatment period. Finally, medication is not the entire treatment plan. Evidence-based psychotherapy is an important component of depression treatment, and for many patients, the combination of psychotherapy and pharmacotherapy provides significant benefit. On a board question, don't overlook psychotherapy simply because the question is discussing medication. Let's finish with the associations I want you to be able to answer without hesitation. Remember, fluoxetine equals a longer half-life. Paroxetine and venlafaxine can both have discontinuation symptoms. Sertraline, you want to remember GI effects, especially diarrhea. Citalopram, QT prolongation. Fluvoxamine, OCD and CYP interactions. You also want to remember elevated blood pressure with venlafaxine. Duloxetine is depression plus pain. Bupropion is a dopamine and norepinephrine inhibitor. You want to remember smoking cessation. Fewer sexual side effects, but avoid if there's a seizure risk. Seizure disorder, anorexia or bulimia, you want to avoid bupropion. Mirtazapine, you want to remember mattress and munchies. It causes sedation, appetite increase, and weight gain. Trazodone is good for insomnia, but you want to remember orthostatic hypotension and priapism. TCAs can cause anticholinergic effects, orthostatic sedation, and dangerous cardiotoxicity and overdose. With a TCA overdose and a widened QRS, you want to remember sodium bicarbonate. Clomipramine, OCD. MAOI, you want to remember tyramine and hypertensive crisis. Atypical depression, remember that MAOI association. And fluoxetine before an MAOI, at least 5-week washout period. Serotonin syndrome, you want to remember clonus and hyperreflexia. Paroxetine and venlafaxine are high-yield discontinuation medications. And then for its augmentation, you want to remember certain second-generation antipsychotics. And that wraps up Antidepressants Made Simple. For your PMHNP boards, remember that you don't need to memorize every detail about every antidepressant. Focus on recognizing the high-yield connections, the medication class, mechanism, major side effects, contraindications, important interactions, monitoring, and most importantly, which medication best fits the patient in front of you. Pay close attention to the clues in the question stem because details such as weight gain, sexual side effects, seizure history, neuropathic pain, blood pressure, QT prolongation, discontinuation symptoms, clonus, or a widened QRS may lead you directly to the answer. If this video helped make antidepressants easier to understand, subscribe to PNB Wellness Academy. Save this video for your board preparation and share it with another future PMHNP. Continue studying the concepts, but also practice applying them to clinical scenarios because that is where the pieces really start to come together. Thank you for learning with me, and I'll see you in the next Psychopharmacology Made Simple review. Remember, don't just memorize the medication. Recognize the patient, recognize the clues, and choose the safest answer.